The Case Western Reserve University School of Medicine is pleased to join ClinicalRM in hosting today's very special program, Learning from Ebola, Preparing for the Next Epidemic. We're particularly pleased to be hosting Dr. Jerry Brown from Monrovia, Liberia, at his first public appearance in front of an audience of U.S. medical researchers and physicians. As many of you know, Dr. Brown appeared on the cover of Time magazine as their Person of the Year, the Ebola Fighters, last year. Welcome, Jerry, and thank you for being here. Dr. Brown joins a group of equally distinguished international experts representing the World Bank, the United States Army Medical Research Institute, ClinicalRM, and our own School of Medicine. Tonight's conversation promises to be an exciting and timely one, especially in the light of some recent developments. The discovery that Ebola virus has the potential to lie dormant in patients who have been treated and cured of Ebola, and two, the recent outbreak of dengue fever in India. It was also only 1 year ago that the Ebola virus reached the United States. We all remember the public's feeling of fear and how quickly information and misinformation spread, even here in Northeast Ohio. This evening, we'd like to focus on the lessons we've learned from the Ebola outbreak so that we can better prepare ourselves for the next big disease outbreak, epidemic, or pandemic. Global health has been a focus at Case Western Reserve University School of Medicine for many years, reaching back into the late 1980s when the Center for International Health was established to help link the resources of the university and its affiliated institutions to international health organizations and agencies. Our Center for AIDS Research and the Center's Tuberculosis Research Unit have helped to develop much-needed research and research infrastructure in developing countries. For example, our scientific research relationship with the government of Uganda and the Makerere University has not only focused on AIDS and tuberculosis, but has also fostered over 200 Ugandan scientists and healthcare professionals who are actively involved in our collaborative programs. In addition, Case Western Reserve Department of Family Medicine's Global Health Track and the Department of Medicine International Health Track train primary care physicians to become global health practitioners based on the principle that healthcare is a fundamental right for all nations, ages, genders, and ethnicities. These programs have also developed the critical global health research skills that our students will require to address evolving global health problems. The Rotman Family Foundation provides scholarships to our medical students to undertake research activities in international infectious diseases. I hope that you enjoy today's discussion and that we can all walk away better informed on how infectious disease connects us all in a global community, and that there is still much we need to know and do about Ebola and other emerging infections in order to diminish the threat to people everywhere. And now I'd like to introduce Vicki Tift, the CEO of ClinicalRM. Vicki Tift founded that company in 1994 to respond to the need for clinical research services for two of the nation's largest federal research laboratories. She recognized the need for a centralized clinical research center and helped establish the Walter Reed Army Institute of Research Clinical Trials Center. She continues to work alongside military and government researchers through the U.S. Army Medical Research Materiel Command. ClinicalRM helps to manage FDA-regulated basic, applied, and clinical research programs for the Army, Navy, and Air Force, as well as the National Institutes of Health. At its helm, Ms. Tift has helped to grow the company from 3 employees in 1994 to over 475 today, providing full contract research services to government, commercial, and academic institutions. ClinicalRM continues to support the bioscience industry in their search for cures for infectious diseases, as well as responding proactively to health crises in the U.S. and abroad. Please welcome Vicki Tift.
Thank you, Pam. So I wanted to thank Dean Davis, Dr. Robert Salata, the School of Medicine, and the ClinicalRM staff for their tremendous effort in making this event possible today. The individuals that you'll hear from today have done extraordinary work in the fight to understand and to stop one of the deadliest and fastest moving viruses in recent history. When I reflect on their commitment and dedication to making the world a better place, I'm reminded of a quote from Desmond Tutu. Do your little bit of good where you are. It's those little bit of good put together that overwhelms the world. The individuals you'll hear from today do not see themselves as heroes. They'll all tell you that they did what they believed was the right thing to do. It would have been easy for them to walk away from the overwhelming events of the Ebola crisis, but they didn't. They chose to give what they had, and in doing so, they encouraged others to do the same. Our keynote speaker today is Dr. Jerry Brown. In the beginning of January 2014, Dr. Brown accepted a position as the medical director of a missionary hospital in Monrovia, Liberia. He had recently graduated from medical school and was looking forward to beginning the next stage of his career. What he didn't know was that everything about him and everything about his career was going to be tested. Over 2014, Jerry, his wife, his family, and his staff would be tested over and over again as the Ebola virus ravaged their communities and their hospitals. This young doctor, who was recently trained in neurosurgery, found himself in the middle of an infectious disease outbreak, the likes the world has never seen before. It would have been easy to walk away from his patients, but he didn't. His wife shared that she was worried, but she could see his passion for doing the right thing for his patients and for his staff. So, armed with a strong faith in God and a strict adherence to infectious disease precautions, Jerry continued to care for one Ebola patient after another. It was during this time that I met Jerry, and we joined together in a partnership to conduct Ebola research with many others, including Dr. Robert Salata and the folks here at Case Western. I have a video that was shot in West Africa and in the US over the past few weeks. The video helps to describe the horror of the Ebola virus, what it did, and our commitment collectively to helping the people of West Africa through clinical research and capacity building.
That very beginning was just an ongoing onslaught that you just couldn't stop.
A lot of horrible, terrible experiences. A lot of things that you have never seen before.
I remember the exhaustion and watching those bodies just 1, 2, 3 go into the back of that pickup.
Then I lost my mother, I lost my father, I lost my wife, I lost 2 of my brothers, I lost my sister, I lost 2 of my children, then I lost my stepmother.
In our house, we lost about 6 people. Yes, including my 2 children.
Very bad, very bad, very bad. So my people dying. I can't help them, I can't do anything for them.
We never ever want to get caught like that again, ever, 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 ever.
The main need right now is for an effective therapeutic against Ebola. And I had been thinking about the idea of convalescent plasma. Really no clinical trial had ever been done to demonstrate whether it was effective or not. There was no precedent for doing apheresis in West Africa. So we came up with the idea of a bloodmobile.
But we still keep on praying.
We were able to do the first trial of a therapeutic for Ebola in West Africa. We saw this really as a collaborative effort between ClinicalRM and the local principal investigator and the local staff. In addition to doing our own trial in Liberia, we collaborated with the University of Liverpool in establishing a trial in Sierra Leone. There was a lot of infrastructure development that went into improving the physical capability of the blood bank, providing refrigerators, freezers, apheresis equipment, and training as well.
They seem to see the potential in me. I have never been involved in a clinical trial, but they realized that, they could work with me, they could, train me and empower me, and I'm most grateful for that.
This is where we store our research samples.
The ability for CRM to put people on the ground and actually develop the infrastructure on the ground is what's key. The most pressing question is, are the vaccines and therapeutics that we're currently implementing over there, are they going to be efficacious? The survivors are the key. They were able to survive an infection when a lot of people couldn't. And that's because their immune system was of a particular state that had allowed it to occur. A silver lining of this outbreak, if you can think of it that way, is there's a lot of survivors. There's a lot of people for us to examine and evaluate and assess to look at their antibody responses to determine what's that perfect profile, what's that perfect characterization that we want to develop for the future. The survivors have gold in their blood. They don't even realize it, but they do.
It's my pleasure now to introduce you to our keynote speaker, Dr. Jerry Brown. Dr. Brown is a Liberian-trained physician and one of 2 surgeons in Liberia. He's the principal investigator for ClinicalRM's Ebola studies in Liberia, and he worked closely with us to respond to the Ebola outbreak in late 2014. And he led our clinical trial efforts to evaluate the safety and efficacy of Ebola convalescent plasma for the treatment of Ebola virus disease. He continues to work with ClinicalRM, studying the long-term health effects of Ebola in survivors. And he works closely on Ebola's survivor initiatives by responding to the needs of local communities that have faced devastating consequences from the Ebola outbreak. Dr. Brown was recognized as Time Magazine 2014 Person of the Year. Please welcome me in welcoming Dr. Jerry Brown.
Good afternoon. Thank you, Vicky, and thank you, my dear audience, for having me here today. For the sake of time, I will go directly into my presentation. I'm the medical director for the ERWA Hospital from Central Liberia in West Africa. I'm married with 3 kids. I have a Bachelor of Science degree in chemistry from the Epidemic College of Medicine in Liberia, from the University of Liberia, and then went to the Epidemic College of Medicine, where I became a general practitioner. And then in 2008, I joined the Pan-African Academy of Christian Surgeons, a group put together by a group of Christian surgeons in America to train 100 surgeons to cover Africa, various African countries by the year 2020 to ensure we have 100 surgeons. I'm the 31st graduate from that group, and I have other certificates. I just went back to Liberia and then began to serve as medical director in January of 2014. In the ending part of 2014, I then became principal investigator for ClinicalRM in conducting a series of trials. I have a series of awards that I'm not interested in much, but praise God for them. The government gave me something called Golden Key Award. I don't know the meaning of that, but I accept it. I have Grand Master of the Order of the Star of Africa. Praise God for that. Then I became Time Magazine Person of the Year, among the 100 most influential persons. And then last year I was honored as the Civil Servant of the Year in Liberia, 2014. Liberia is on the west coast of Africa, and it's a tiny country. Then we are bordered on the north by Guinea, and the west by Sierra Leone, and on the east by the Ivory Coast, and we have a long coastal line where we have the Atlantic Ocean. This is the hospital where I worked before Ebola, the Eternal Love Winning Africa, and that where you see individuals, this is our emergency room, the entry point into our emergency room. And this is where I worked. And this is the chapel, which we did refer to initially as ELWA1. It's ELWA1 because there is where the first ETU in the capital, Monrovia, started. We actually had it open as a holding unit, but later turned out to be a treatment unit. Our first meeting to discuss Ebola, where I chair, was on the 28th of March, where my co-worker, I had about 3 family medicine practitioners, in person Dr. Sikra, Dr. John Fencastle, and Brindley, and then Dr. Debbie, a surgeon, was also working there with me. These are all missionary doctors. Then I had a Nigerian, a Congolese working with me, and I was there chairing the meeting. And during that meeting, someone decided to add on the agenda for discussion Ebola, since Ebola was next door in Guinea. At that point, we started making preparation on how we could prepare ourselves, just in case we had a positive patient at our emergency room. And so our goal initially was to establish a holding unit where patients would be kept and tested before sent to a possible treatment unit. Because at that time, there was no testing center for Ebola in Liberia. We could not do PCR anywhere in Liberia. And so this was our first team. Dr. Brindley, Fencastle, and Debbie were asked to first serve into the unit, and then I continued to work in the hospital as a general physician and working with the other physicians to attend to patients. Because what we read and learned earlier was, once you were attending to patients in the Ebola unit, you should have no contact with patients within the hospital. And that's what we learned earlier. But we later proved that wrong, because we worked in the ETU and also worked in the hospital, and there was nothing like cross-infection. No one got infected as a result of that. Okay? Between March to December, nationwide, we had a total of 8,000 cases now. At this time when we had our first meeting on the 28th, by the 30th of March, the first case hit the northern part of our country. And we were shocked. Wow. When they come to the capital soon, we never knew. But that caused us to intensify our preparation. And then by December, marching from March to December, 8,000 and more cases were already attended to. we had note the two numbers. The suspected patient was about 3,180 by December, with confirmed patients who were tested positive, 1,102. This because of the limitation in getting people tested to confirm the disease. There were limited testing centers. So people during that period who died of the disease, who died within the country, were considered positive, since some were not tested. And so we never knew exactly whether we can't pinpoint exactly today to say, yes, the exact number of persons who die of Ebola is this number. Okay, so whatever figure we are presenting is just an assumption. But the confirmed patients that were tested within that period were like 3,102. The total death was a little over 3,000 by then, and about 370 health workers were already infected by December, 178 of whom died. Though over 8,000 cases were reported in 2014, the Ministry of Health statistics shows that only 42% were laboratory confirmed. Initially, we decided to use what we had available after we held our discussion. Tyvek suits were not available, but to conduct our training, we decided to use our OR gowns, use plastic apron, use our OR caps and masks. And the basic behind the training was to ensure you executed safe methods, safely getting rid of whatever you wore to attend to the patient, safely attending to the patient from one to another, safely interacting with your colleague, and safety is what we try to lay more emphasis on, okay, in the absence of what we needed to work. So we conducted our training and decided to train all of the staff in the hospital. By this time, there was no ETU in the capital. An ETU was established when a single patient passed through the capital in April, but because that was controlled, the government and other partners felt everything was over. So from April to June, nothing was done. The ETU that was set up was shut down, but we kept ours open because we never knew what would unfold in the next weeks. The fact that there were still patients in Guinea and Sierra Leone. So when I first took over as medical director, one of my primary goal or project I put together was to renovate the chapel. I felt I should start by fixing the house of God. And just after renovating the chapel, then we had the outbreak. So the renovated chapel, we had to turn it to be an ETU. So this is the chapel where support staff, cleaners, accountants, dentists, and all of the staff in the hospital got trained on the various safety measures. So it was not a matter of choice, it was mandatory. So no one had to decide. There was not inadequate availability of training material, come to talk about who to do the training. So the material we used for training were gotten from the web, previous WHO document, previous Medicine Sans Frontières documents, and we modify it for our setting. And then recruitment of staff was one of the basic challenges we had, because most of the staff were afraid and fear of the unknown. We never knew, no one wanted to get infected. The fact that there was no insurance coverage, the fact that there was no lucrative incentive for paying you for working into the treatment unit, and there were others who had died already. So it was challenging to recruit staff to work. And so the question that came to me all of the time by my colleague was, we need nurses and PA to work along with us in the ETU. and it was now a challenging thing to go back to the nurses and spoke to them to go. Now, our goal for establishing the unit was primarily the safety of our staff. How can we continue to offer services and ensure our staff remain safe? And we never wanted to shut down basic services at the hospital, as was done by most of the basic referral hospitals. They shut down their doors, packed their bags, and the hospitals became closed. But there were still other infectious diseases existing. And I think there is where the international community, or all of us, missed the mark. We were focusing primarily on how to curtail the outbreak and took our attention off other diseased entities that were existing. So people continue to die from hypertension, people continue to die from acute abdomen, people continue to die from obstructed liver, people continue to die from malaria, die from many other disease entities, and people were all focusing on Ebola and took their mind off other disease conditions and how to isolate this patient. Now, when we started to engage the staff, we first started using our position and authority. No, you must walk into the unit else you get dismissed. But these are some of the responses that the workers begin to give me as I begin to ask them to walk in the unit or get dismissed. Some say, I'd rather resign. Don't worry to use your pen to write me a letter of dismissal. I'll give you my resignation tomorrow morning. And some say, well, I can do anything you want me to do for you, but get into the unit? No, 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 no. Some say, I'm not willing to leave my family and sacrifice my life. I'd rather stay with my family. If I get infected, fine, but I'm not going to the ETU. And what was shocking to me was, man, we've trained you and you show up for the training. Now it's time for us to fight. And you say, no. They say, well, that's a different thing, doctor. I can't, we're not going to do it. But we tried to persuade a couple of them this time around. Instead of speaking to them in group, we decided to engage the workers on a one-to-one basis. So I'll call you or call you in the corner and we talk one-on-one and try to persuade you to see reason to want to work. And the first day we managed to get 2 that went into the ETU, and then finally we put out another bet of ensuring that they volunteer. And then the Ministry of Health later came in and began to provide incentive. Most of the patients that we got at the ETU came by means of ambulance. Some walked in, some were brought on taxi, some were brought on motorcycle. A back rider is sitting there and a positive patient is riding at the back of the bike. And then you have a positive patient in the taxi riding with others. And that's the situation we have because people never knew what they were dealing with. It was shocking when we got our first 2 patients on the 12th. The 2 physicians that brought in the patient, it was shocking to see them, one sitting in the back of the ambulance with the patient. And then we put our hands on our head. Oh, these people don't know what they are dealing with. And that's what was unfolding at the beginning. People never knew what the disease they were dealing with. They had no knowledge about it, how it spread, and how you could easily get it and spread it onto others. But the mechanism of infection was either within a household, because most of the houses we have in Liberia, you have several families living in a single house. So you have 8-room house with perhaps 30 persons living in that same house. So if one family head got infected, the feasibility of having it spread to other rooms, because you have one room with about 8 persons living in it. And so the region of the capital where the poverty-stricken region in the capital is where you had the disease spreading out mostly. Like you might have heard about West Point, you might have heard about and Soul Clinic in Liberia, because those areas were densely populated area, and the people there, their livelihood and sustaining themselves was very, very, very poor. So people got infected also from their fellow health worker, or while attending to patient, or attending to funeral, where there were traditional rites people still were performing. There are a lot of myths people had when someone died. They have to bathe the body. Some tribe has this traditional belief where if a powerful family member died and you bathe the body and the fluid or the solution may be pasted on the head, that will transfer the power to other family members and all kinds of things. Some will even go to the extent of drinking such fluid from a body that was bathed because they felt it was a means of passing on the strength or power from whoever might have died. And all of those traditional beliefs led to a rapid spread of the disease at the genesis of the crisis. Some causes of rapid spread, I've dealt with this already. So one of the things I want to talk about on this slide has to do with the laboratory diagnosis for the disease at the genesis of the conflict, of the outbreak was not possible because there was no lab in Liberia where one could do testing. So it took like 3 days before you get a laboratory result. That's how we started. And then it went to 24 hours when a lab was established at LIBR, okay? Before we later got CDC coming in, and then by September, we could now get our lab result within 8 hours of the day. So it was challenging to make a decision in separating a suspected patient from a confirmed patient. So the patient might have deteriorated before you actually came up with a decision. And that was very challenging for us. Contact tracing was delayed initially because the staff that were recruited initially themselves were afraid of going into the communities, of fear of getting infected with the disease. So when they were sent to community to go and get to do contact tracing, they wouldn't go. And so these were challenge situation we had. Now here, this is how we started with our triage system. If you had a contact with the patient or touched the skin of someone who died or attended a funeral, and we then triage you based upon the signs and symptoms you presented with, and then put you in one of these categories. Either you were a probable case, a suspect, or a confirmed probable or suspect case. Sorry, I think there's an error right here. Okay, the suspect here and this should be probable and confirmed. So, but at the end of the day, this triage did work effectively for the ETU. For us at the hospital, we used this triage format and formulated our own triage format for the hospital and for our staff. Now, this is what the ETU did look like. Patients entering the ETU came through this security checkpoint down here. You got, come on, this is not, so here, through the security checkpoint, you enter and wash your hands, and then you went to the nursing station, the changing room, and then you had donning done here before going to the suspect or probable zone, and then the confirmed zone where I have in red. Ambulances came at that point where the patient got off and went to a waiting area, and then the staff will come from here, go around, and came back to collect the patient, brought the patient in, and you were placed in the suspect area until your test result was obtained. If you were tested positive, we send you forth to A or B. If you were having history of or getting in contact with a patient and you were having obvious symptoms like bleeding or loose stool, we never kept you in the suspect. We took you straight to probable while awaiting your test results, because we never wanted you to have interaction with those with dry symptoms. Maybe you only have fever, headache, and no diarrhea, no vomiting. So we never wanted you to interact with such person. Our staff to patient ratio initially was challenging. When we had ELWA1 or the chapel, we had 6 staff, 2 medical doctors, 2 nurses, and 2 hygienists per day, because it was challenging to recruit staff So if we could manage to get 4 persons agreeing to work with the 2 doctors, we accepted. And later on, when the kitchen and the laundry was now turned to be our now treatment unit. This is now where we had the kitchen and the laundry, and where we have confirmed A and B was the outpatient department. The suspect and probable, the suspect was our kitchen, and probable was the laundry. And then confirmed A and B was the outpatient department that we annexed. Lately in November, a German NGO built 2 tents for us, which we call extension A and B. That increased our capacity to 100 patients, our bed occupancy. But when we had an occupancy of 20 in the kitchen and the laundry, we had now a workforce of 32 persons, 2 doctors, and a staff of 30 distributed as such. 2 doctors, 16 nurses, 4 physician assistants, and 10 hygienists. And that's what we used even when the bed occupancy increased to 40. Because even at that time, the nurses and the PA were still hesitant to come and work at the ETU. Initially, we read about this non-touch policy, where you don't touch the patient, you kept 3 feet away from the patient, and then you gave the fluid and stood away. There was nothing like giving bedside care to the patient, and they were neglected more or less. And that also contributed to their mobility and mortality. But when we took over, we decided to change it. All of a sudden, we began to give patients bed bath, because the message we sold out to the staff was, if you dress properly, if you did your donning well and did your doffing well, there's no need of you getting infected with the disease while attending to the patient. And for us who was in leadership, we decided to demonstrate that and allow the other staff we led them by example. So we're not only giving instruction, but we got down on our knees, establishing IV line, taking them off the bed, changing their soil lining whenever they defecated on themselves, because most of them were helpless. And so we had to do everything possible to help them. And so the nurses too, when they saw their leader involved in such things, they came on board and began to work along. So it was nothing like you, the physician, you were responsible to only write and give orders. So we're also involved in the actual nursing procedures. Okay? So we started with aggressive fluid resuscitation, clinical care, supportive care, and then another goal of boosting the patient's immunity. Because we felt if we boosted your immunity, your body will have the ability to fight the virus itself. So we never focus only on fluid resuscitation. There were a lot of challenges in terms of investigation. We could not do CPC in our ETU. So to determine whether the patient was anemic before doing blood transfusion was clinical presentation. Looking at the conjunctiva, looking at the palm. If we felt you were anemic and you were bleeding, and we looked physically and saw any sign of anemia from physical assessment, we transfuse you. Okay? And creatinine, we couldn't get, but if we came back in a couple of hours and asked you how many times have you passed urine, you can say we left a container with you and you voided in it. If the volume of fluid you produce is not compatible with what we've infused already, then we begin to think you run into renal failure and begin to give more and more fluid. So electrolyte analysis was not possible, no way to do malaria smell, no x-ray, ultrasound, delivery kits were not available. But we had to do something. So establishing IV access for all of the patients was mandatory. That's something we put in our protocol. So if you came walking in and even was a dry patient, meaning you are not vomiting and not having loose stool, we established an IV access because we never wanted you to start deteriorating, especially children. once they deteriorated, getting an IV line was now difficult and challenging. Okay, so we monitor the fluid intake. Now, these comorbidities were difficult to manage, and depression and psychosis were one of the most challenging things we had to take care of. One of the patients developed psychotic symptoms, though he had recovered, but he committed suicide. It was from there we sat down, thought how to manage that. So we started to use Hadol. And once we sedated you for some time, within the next 48 hours, we realized they will recover and did well. But these psychotic symptoms came at the latter stage of the disease when they are about to recover. That's when we saw it, not at the early stage. So it was mostly when you are about to recover. We performed a couple of deliveries at the ETU. One was at times at the, within the ambulance. This was performed. And interestingly, these mothers were rejected at other institutions. And so when they brought them, we attended to them. As God will have it, the mother and the kid were negative. So if we had rejected them as well, they all perhaps would have died or something would have happened. But this when we were doing our clinical trial, these patients receiving plasma within the ETU, and we're also providing supportive care. One of the things that evolved with time was providing identity of the staff. So we later had a group help us to provide portrait of the staff. So we pasted it on our ETU, on our PPE, and with our name rating, and to give the patient an opportunity of knowing who was interacting with them. And patients were fed because they were very weak. Because of time, I will run through this slide easily and rapidly. All of the patients were mixed together. This was one of the challenging things we had. It was demoralizing to see the kids with their parents in the same room and having lose to. It wasn't a good condition for both the parents and the children. Some kids saw their parent dying in their presence, and it was difficult and challenging. Source document was difficult to manage. We started all by reading it out to the staff outside, then we progressed to taking photo of the source document and then showing it out to someone to copy, and then finally progressed to scanning the document after we came in contact with ClinicalRM. They bought the scanning. We could now scan our document and scan it straight out to the computer. As a result of our intervention, initially the survival rate was like 10% when we started. We realized it increased to 60 to 70% for some months. That's how our survival rate then kind of increased. We changed some of the thoughts people now had about the disease. Instead of saying once you got infected with the disease, you will die, we begin to produce survival begin to come out, and then the radio stations now change to, if you presented early, you could live from the disease. And that caused our unit to became flooded with a lot of patients. People were now saying to the ambulance driver, take us to EOWA 2. We don't want to go to anywhere else. If you can't take us there, take us nowhere. And that increased our workload. At our ETU, between the period concerned, 704 patients were admitted. We had a total confirmed patient of 523. The total confirmed death were 229. And then the total confirmed discharges, meaning survivors, we had 234. Out of the total admission, there were 181 persons who were tested negative for the disease on 2 occasions, and we call them not a case. 71 of those died within the ETU, but died in the suspect section. So they died of other disease condition, and 170 persons got discharged without being tested positive. The interesting thing about this, all of the patients with discharge from the suspect zone never came back positive. That was one beauty we had. Okay, we had to shut down the hospital, and I think I see him showing out. Let me just show this. Here, these were our first 2 medical survivors. This is a nurse who prompted me to go into the ETU. And this is one of the first medical doctor to survive at our unit. Dr. Paps is one of the doctors who helped me, the one with this, who was working with me at the ETU. And these are some of our survivors on their way home and being certificated, children as well as adults. This Indian who was admitted, at the other time we gave glory to God for a couple of persons getting infected, because through them we got more support. When he survived, we got more support from the Indian community to help our unit. This unit was the only unit that was not supported by an NGO. It was not until November before that NGO came and did the extension. But we never had any direct support from WHO or any MSF or what have you. These are other survivors on their way home. And this is one of our patients that survived from receiving convalescent plasma. And so we are involved with ClinicalRM doing RG fractionation, and we're also currently conducting a survival longitudinal study. One of the best practices we had in Liberia had to do with washing of hands. So at all public facilities, there were buckets set up for washing hands at school, at churches, at mosques, at ministry, even the executive mansion. You have washing hand points. In communities, you could not enter certain community without washing your hand. It came to a point where the community leaders themselves took charge and had washing hand points in the entry point of the community. So you only enter the community if you don't wash your hand. These are my nurses. They are always excited and happy whenever we have our patients being discharged. Let me stop there and say thank you very much. Sorry, I went over time.
Thank you, Jerry.
Thank you.
Thank you so much, Jerry. I think we're all amazed at the resilience and the commitment and the passion that one individual had, and his ability to stand up and lead and show his staff what needed to be done, and they followed him. I think what he didn't mention to you was that no one in his unit, in the Ebola treatment unit, none of the healthcare workers passed away, and that's a remarkable achievement. I'm now very honored to introduce you to Dr. Robert Salata. Dr. Salata is the interim chair of the Department of Medicine at Case Western Reserve University and University Hospital's Case Medical Center. He's a professor of medicine, international health, biostatistics, and epidemiology at Case Western Reserve, where he has been on the faculty since 1985. He is also a master clinician in infectious diseases. His career has been marked by excellence in clinical care, teaching, and research. A large part of his focus has been on the epidemiology of infectious diseases, drug resistance, infection control and prevention, as well as antimicrobial stewardship. Dr. Salata has been recognized regionally, nationally, and internationally for his contributions to the field of infectious diseases and antimicrobial resistance. Dr. Salata has also been a valuable partner to ClinicalRM for many years and has a passion for global health, research, and making a positive difference in our world. Please welcome Dr. Robert Salata.
Good afternoon, everyone. What we'd like to do is have our other panelists come up at this time, and we're going to set up some chairs. Each one of these individuals, as you'll hear, have had a large hand in assisting with the whole conduct of care and research in and around the Ebola outbreak in Liberia and other surrounding countries. So as we have them come forth, we will have all of them present who they are, what they did, and then we'll end up with some capability of having questions and answers from the audience I have some in my back pocket if we need to, but we'd like to start with John Dye, who's the chief of the viral immunology at the USAM Research Unit, Institute of Infectious Diseases. John has spent a great deal of time in Africa, was involved in this process. John, please tell us about yourself.
So I'm a loud speaker, so I'll probably be moving a lot. I like to move around, so I apologize ahead of time. My name is John Dye. I'm the chief of viral immunology at USAMRIID, which is the United States Army Medical Research Institute of Infectious Diseases. It's in Fort Detrick, Maryland. And I'm not in the military myself, but this is the way I chose to support my country. I've been doing Ebola virus research for over a decade now. I did my undergraduate work at the College of William & Mary in Williamsburg, Virginia, and then I went on and did my graduate work at Loyola University Chicago. I have a degree in microbiology and immunology, a PhD, and I started a postdoc in 2003 at USAMRIID, and I've stayed on there afterwards. So we've been working on Ebola for decades now, actually, since the 1980s. The first recorded case of Ebola was in 1976 in the DRC. And ever since then, the U.S. Army has been trying to develop vaccines and therapeutics for that. I tell an interesting story. So my wife's a professor at a university, a local university in Maryland, and we would go to dinner parties. And before 2014, we would introduce ourselves, and I would introduce myself, and I would say, I work on Ebola virus research. And within 30 seconds, I get the deer in the headlight glazed over look because nobody had any idea what I was talking about. And she would introduce herself, and she's a professor at a university, and everybody would pay attention. It's reversed a little bit now. Everybody knows about Ebola, but the immediate response I get is this. Nice to meet you. It was interesting. I went to the dentist, and they were asking if I had been over to Africa, and I told them yes, and the lady who was going to clean my teeth could not leave the room quick enough. We had a consultation with the dentist, and we discussed where I was and the fact that I had been through the training, the program after, about being observed by the CDC, and that it was safe, and he or she would be happy to work on me. So I just wanted to basically run through. I work at USAMRIID, as I said. Our basic mission is to protect the warfighter, protect the U.S. soldier. So you may ask, why is the U.S. Army interested in Ebola virus? We are looking at emerging infectious diseases. We're interested in case we have to send a soldier or his family to an area that's endemic where Ebola has been, but that doesn't happen very often. We actually were more interested in it because before the fall of the Iron Curtain, the Russians were actually weaponizing Ebola. So we actually are interested in a biothreat capacity, which is why we've been working on it for so long. So we've been developing vaccines and therapeutics for the last several decades. All the vaccines that are currently being assessed in Western Africa and around the world were either developed or evaluated at USAMRIID. That's something you don't really hear about. I've worked on the adenovirus vaccine, I've worked on the VSV vaccine, I've worked on multiple vaccines. All the therapeutics that are currently being tested. Matter of fact, ZMapp was actually developed at USAMRIID. One of the 3 components of ZMapp was developed there. We're doing all the FDA clinical trials for the animal rule for ZMapp. All that work is going on at USAMRIID and other prestigious institutes around the world. There are 800 employees with over 200 physicians, veterinarians, and PhD scientists. What's really cool about working there is I can have an expert in melioidosis or an expert in other infectious diseases, and I can go pluck them and pick their brain and learn about different ways bacteria work than virus work or parasites work, and it's a really great environment for working. I feel a bit sheepish showing pictures like this because this is how we work with Ebola after seeing Dr. Brown's pictures of how they were working with Ebola. We wear this blue Dover suit with a permanent air supply, and you can do anything. This is a BSL-4 environment, biosafety level 4. It's a positive pressure suit. Everything flows out of the suit, and all the rooms are under negative pressure, so everything is flowing into the room from outside. You can do anything in a BSL-4 that you can do in a BSL-2, a laboratory that you have, just benchtop laboratory. It just takes a hell of a lot longer to do it. So, as I said, we've been working on vaccines at USAMRIID, and I personally have been working on vaccines for the last decade. We've also been looking on therapeutic development. So I think in the panel discussion, I'm honored to be included with a group like this. In the panel discussion, I think they may be looking to me for a lot of scientific components, and being here at CASE, I'm sure we'll get a lot of great scientific questions. And I was honored. I actually was in Uganda when I got a phone call from the gentleman I believe he'll be speaking next, which is Dave Hoover. I was in Uganda looking at survivors of previous outbreaks of filoviruses. I was the cheese ball in the video who was talking about how the survivors having gold in their blood, and I truly believe that. I believe that they are the key for us understanding, looking at their immune system, what allowed them to survive genetically or because of the status of their immune system is going to be the key to help us understand how to go about fighting this disease. But I was in Uganda and Dave Hoover called me. He said, hey, I read your PNAS manuscript where you took plasma from monkeys that had survived a vaccine study. You collected that, you fractionated the IgG, and you put it back into monkeys that were then challenged with Ebola 48 hours after, and we got protection. We were the first ones that were able to do that. He said, I got this idea. I want to do plasmapheresis, and I said, that's great, and I got on board immediately. I couldn't wait. So our purposes, what USAMRIID has been doing is we've been providing real-time PCR results to determine whether the survivors and the patients that are receiving the product are Ebola positive or Ebola negative and what their viral load is. In addition, the samples are coming back to the US and we're analyzing those samples for IgG and IgM levels, looking at virus-specific antibody, as well as functionality of those antibodies, neutralization, ADCC, all those components of the immune system. The last thing I wanted to say before I'll get off the stage, because I think a hook's coming soon, is that we've been looking, as I said, with the Ugandan Virus Research Institute in Entebbe, Uganda, and Ben Gurion University in Israel. We've been looking at the survivors in Uganda from Marburg, Bundibugyo, and Sudan virus, which are other flavors of filoviruses or Ebola virus. They actually don't have Zaire, which is the current strain of virus, or Makona, that's going through Western Africa right now. And we've been trying to generate human monoclonal antibodies from these survivors as a potential therapeutic, because ZMapp, that magical elixir cocktail that has gone into some patients and provided some help, we believe, is specific for Zaire. It's not going to work against Sudan. It's not going to work against Marburg. So we're going to have to develop individual cocktails against each one of them. And that's one of my missions that I'm trying to do. And maybe more importantly, we're actually tracking and following the immune response in these individuals over time. So we've actually looked at these individuals from 2000 until now. So we have 14 years of data looking at their B and T cell responses over time. What's their memory B cell population, their memory T cell population, and how has it changed over time? Because I think it'll give us a good indication of what we need in a vaccine. These people are able to survive, they have a good memory response. This is what a vaccine should do as well. So. And this is just some pictures of us from our work in Uganda. And this is the group that I work with. And as I said, thank you very much for inviting me to attend.
Next, we have Craig Giese, who's a Cleveland native, loves the Cavaliers, among other things. I know that for a fact. But he's with the World Bank Group and has really had very significant conversations with us about how to work together in a cooperative and collaborative fashion to start dealing with the devastation that's been left behind in the aftermath of Ebola. Their public health infrastructure and their financial infrastructure was poor to begin with. But imagine what it's like now. So, Craig, please.
Thank you very much, Bob. I'd love to say that I'm a scientist or a medical doctor, but I'm not. You're going to get a different perspective from a simple investment lawyer. At the World Bank, we're an international development organization. We look at Ebola from a slightly different perspective. It's a perspective of how it has stunted economic development in what we call the so-called hot zone countries and the rest of the region. Our mission at the World Bank, eliminate extreme poverty, boost shared, inclusive prosperity in the developing world. You can see here a nice little outline of our history and our organizational structure. We work around the world. Now, if you ask any West African and saying, but we're particularly interested in the ECOWAS region, a West African knows what ECOWAS means. But in the United States, not so much so. It's actually the economic community of West African states. It's an economic union. Its goal is to become like the European Union. And here's a snapshot of it. You have 5 Anglophone countries, 10 French civil law countries. One caveat for us, and one caveat for even medical practitioners or scientists, is that an approach that can work in Sierra Leone, Liberia, or Nigeria may not necessarily work in a Francophone country, such as Senegal, where I currently live. Foreign investors have been very interested in Western Africa before, and surprisingly even after Ebola. And there's reason for that. There's quickly growing populations. This economic union comprises approximately 360 million potential consumers, merging middle class with money. And as a result, experts have highlighted certain areas for potential economic growth: energy, agribusiness, retail trade, and yes, healthcare, and even medical tourism. But when you look at this laundry list of problems, what we call at the World Bank market failures or regulatory failures, Western Africa is probably subject to more of these than any other place on the planet. So what do we do at the World Bank? We undertake projects, and the goal of our projects is to make a dent, eliminate, reduce these market failures so certain regions or countries can really realize their full economic potential. One project that we have now that's financed by the European Union is what we call the ECOWAS Investment Policy Project. What's its goal? To increase direct foreign investment in the 15 member states. At which sectors? Many sectors, especially healthcare. Now, what are we worried about in this project? We're spooked by having another Ebola outbreak. Dr. Jerry Brown very eloquently talked about the toll on human lives. But what is also forgotten by many is the economic devastation. If you look at real GDP, Liberia, Guinea, Sierra Leone, they all took very big hits. And they may have been set back 10 years in terms of their economic development. Sierra Leone has just made a recent request to us. They've said, we did everything you said, World Bank. We've modified our investment code in accordance with international best practices, but the foreign investors don't want to come back. Why? Because we don't have in place a post-Ebola economic recovery program. We need your help with that. And this is a place where we, the World Bank, have been in conversations with our colleagues from the International Infectious Disease Coalition. This is a coalition that was spearheaded, created by Case Western Reserve Medical School, together with ClinicalRM. What we're looking at is, if you take a look at the secondary mission, which is of immediate concern for us right now, is helping countries like Sierra Leone or Liberia to jumpstart economic recovery in the aftermath of Ebola. So what are we trying to do right now? We're talking. We're doing dialogue. We, the World Bank, are talking internally with our other global practices. We're speaking with the ECOWAS Commission. We're even speaking with major multinational corporations with significant healthcare operations in Africa and West Africa. We're trying to figure out a way, together with our colleagues at IIDC, how we can structure, put together an effective public-private partnership arrangement so that essentially Ebola doesn't recur as it did before, that IIDC can do what it does best and attack other infectious diseases, and ultimately, at the same time, we improve the healthcare systems of the ECOWAS member states. And our next steps are fairly simple. We're going to continue the dialogue. Thank you.
Next up is David Hoover, a great colleague of mine who is a senior advisor to ClinicalRM, has a military background, was in the video, and he's going to talk about some of the research efforts that were brought into play in the Ebola outbreak.
Thank you, Dr. Salata.
So I'm an infectious disease doc, and I also have a Cleveland connection. I did my internal medicine internship and residency at Cleveland Metro back in the days of Charles Ramelkamp and Manny Walensky. I've had over 35 years of experience in biomedical research, primarily focusing on preclinical studies of macrophage interactions with intracellular parasites or bacteria. And then for the last 15 years of my Army career, I led the Army brucellosis preclinical vaccine development program. And then for the last 10 years, I shifted to clinical research and was engaged in vaccine trials and more recently on antimicrobials. And then for the last year, it's pretty much been Ebola all the time. So in August 2014, there really were no therapeutic options on the horizon. And it was unlikely that a substantial amount of volume of drugs, even if they were found to be active, would be available for treatment of the disease. So we really had two questions. First, we knew that there was anecdotal evidence for treatment of people with Ebola with whole blood transfusions. And so but there had never been a clinical trial. So we asked, is Ebola convalescent plasma actually safe and effective? And secondly, if it is, from a medical, not research point of view, how can we make it available to patients in the severely Ebola-affected countries? So we approached this through the use of two protocols. First was a phase 1/2 pilot clinical trial to assess the efficacy and safety of Ebola convalescent plasma. And this was done at the Elwa 2 ETU that Dr. Brown discussed earlier, with Dr. Brown as the PI. ClinicalRM was the sponsor of that trial, and the Bill and Melinda Gates Foundation generously funded it. The patients who were to receive treatment were to be given 3 doses, 200 mils each of convalescent plasma every 48 hours. And they were assigned to receive either Ebola convalescent plasma or the standard of care based on the time of admission to the ETU and based on availability of plasma that was compatible with their ABO type. The treatment was guided by clinical labs using handheld point of care diagnostic system. And as Dr. Brown mentioned, electrolytes, renal function, hemoglobin testing were not available in the ETU at that time, and we thought it was important to make that capability available to help guide the IV fluid and electrolyte treatment that was being used. The efficacy assessments for that study are the change in viral load after treatment, either with convalescent plasma or with standard care. And for those who received convalescent plasma, the correlation of the change in viral load with the donor anti-Ebola virus titer. And a secondary endpoint actually was survival because of the size of the study. Our safety endpoints focused on transfusion-related adverse events. Now, thankfully, the Ebola outbreak declined rapidly just as we were starting the trial. When this trial started in mid-December, we actually only enrolled 6 subjects because the disease went away. And that's something we're very thankful for. And at the same time, it emphasizes one of the challenges of doing research in an outbreak situation where, unless you're really prepared and ready to go early, you may miss the outbreak. The second protocol was a supporting protocol for collection of convalescent plasma. This was also done at the Elwa Hospital. The survivors were recruited from the Elwa 2 survivors, and we followed WHO recommendations for collection of plasma and processing. An international team went out and set up the bloodmobiles, and a particular bloodmobile at Elwa Hospital. And the Plasma was collected and processed by Liberian staff that were trained in 3 weeks to do this process. The plasma was also treated after collection with a Sorolin UV illumination process to kill envelope viruses and other pathogens as a way of improving potential transfusion safety. And then plasma was frozen and stored for use in the clinical trial. We screened over 100 donors. 26% of the donors were deferred because of transfusion-transmitted infections. That was primarily hepatitis B and about 16%, and hepatitis C and HIV. But over 80 units were collected and processed, and there were no adverse events. And I think that's actually a real testimony to the capabilities of the staff there at the Liberian, at Elwha Hospital, to acquire these skills so quickly. And their care for the donors was very impressive. So I'd just like to stress one more thing, that this was a hugely collaborative effort. Couldn't have been done with the support from philanthropic organizations, the plasma and transfusion community that stood up and sent people and expertise and instruments. The regulators were very helpful. And of course, the site itself, the staff of the site that learned how to do clinical research rapidly and took on the burden of doing clinical research at a time when they were really stressed with many, many patients as we were developing the project. So I'd like to thank them and look forward to hearing some questions later in the discussion.
Last but not least, Joe Skurza, who is the president of ClinicalRM, will give us some perspectives about the company's involvement and the future, also what that has in store for their involvement as well.
Thank you, Bob. My name is Joe Skurza. I'm the president of ClinicalRM, and I'm very excited to be here today. And I'd like to just thank the panel as well as Dr. Brown and Mrs. Brown for coming across to Liberia for this very exciting evening to discuss our efforts in West Africa. I've started about 26 years ago in clinical research. I thought I was going to be a professional basketball player. That didn't work out. But I took a liking to infectious disease early on, and most of my career has been in the pharmaceutical industry. And that was until last year, August 18th, when my supervisor now, Vicki Tift, the CEO who you heard from, gave me a call and said, "Come to Cleveland, it's going to be fun." So very short order, I got another call from a Dr. Hoover, and it was a very different call than Dr. Dygod, because Dr. Dygod got a call to talk about the science. I got a call to find 3 blood mobiles and fly them on a plane to West Africa for Dr. Brown, because it was a short order and an emergent need. So not to bore you, but I want to just explain a little bit about ClinicalRM and how it dovetails with Case Western and Dr. Salada's efforts. We're across the globe. We are obviously located in Hinckley, Ohio. And as you can see, in West Africa, we have a heavy presence, as well as East Africa with our affiliate ClinicalRM Africa. So very similar to a clinical research organization, ClinicalRM has a distinct difference, is that we are thought leaders, thinkers, and we know exactly what to do when there's an emergent need. And I want to stress that for those of you, because there's many scientists and distinguished audience here. Those of you that are thinking about making a difference, doing the right thing, you need to talk to Vicki Tift. She, in very short order, arranged and organized a team, including thanks to the Bill and Melinda Gates Foundation, as well as many others in the audience here who I'm going to give a quick shout out to, organized I would say the A-team, to deploy and get these blood mobiles over to Dr. Brown, which was very sorely needed at the time, as there were really no treatment options. Just a little short overview that there was a rapid response that was needed. Dr. Hoover alluded to about how we developed a protocol in short order, and most CROs don't become a sponsor. When Vicki said, no, we are going to be a sponsor because there's no other folks that will actually step up at this time. We have a treatment. How do we become a sponsor? I said, well, usually we have to become a pharmaceutical company and have a very nice spa and a gym. And she goes, well, we're not doing that. We need to become a sponsor tomorrow. So a lot of the folks in the audience, like our CFO, Wayne Mosley, we have our HR folks here, Jackie Bovinette, you'd think that it's mostly scientists, but it takes a village and a corporate team to work 24/7 in order to do what we had done. So basically, 3 of the key things down on the bottom that I think are noted or of note should be our in-country training. It's very important to understand that Dr. Brown has some of the brightest individuals with limited capacity with supplies and training. But these are very bright individuals that are now doing a lot of the training globally for not only the apheresis that Dr. Hoover's talking about, but they're able to train and leave a footprint and currently are apheresing other areas such as Sierra Leone, Guinea, and Nigeria. So I'm not going to replicate what Dr. Hoover has mentioned, but I'm just going to do this in a past, current, and future for ClinicalRM. As a clinical research organization, we're working with many institutions such as Case Western, and we're really pooling the best and the brightest to find and really discover what Dr. Dye was talking about with long-term effects of Ebola with the survivors and longitudinal studies. And I just want to mention in a couple of slides, for the interest of time, we did get these bloodmobiles on an AN-124, which is a very large aircraft that was positioned in Raleigh, North Carolina for the first time. That was the largest plane ever landed there, and that took off. And I'm the peace sign down below, because Vicki said get in the plane and you need to drive these Hope mobiles off. And I didn't know that was part of the job, so if she ever gives you an application, make sure you read it carefully. But it was an amazing feat because we were able to do this in very short order, in less than a month. And when you know anything, if those of you that know about bloodmobiles and you're turning them to apheresis units, you need a Dr. Hoover, you need a Dr. Melissa Reyes, who's in the audience, you need Claudia Christian, and you need many other folks who I'm not mentioning here, but these folks were instrumental in loading and gathering almost 25,000 items in each bloodmobile that had to be logged in, custom cleared, and out and getting ready for this plane within a month. And that was a very, very difficult feat, but it was accomplished. So I will say, if you can think of it, it can be done. If you can focus on not just what status quo is, but challenge and bring people in who have the expertise, not even the scientific expertise, but maybe someone who has the logistical expertise, that makes a difference in getting your research program moving. Here's a little bit what ClinicalRM does as well. Besides doing the clinical trial, we're also doing, this is at Military Hospital 34, just in Sierra Leone. And we're working with a lot of the survivors that Dr. Brown was talking about. And this is a remarkable thing that ClinicalRM is trying to do in conjunction with a lot of the folks at CASE. What we're trying to do is evergreen the opportunities of what's going on with survivors. They have been through hell and back, excuse my French. They have been through so many different things. So what we're trying to do is give them opportunities, listen to them, ask them to help out. You'll see other initiatives that we're trying to do, which is also help them self-support and give jobs to them. And these are the things that's really important, is we're getting a bank of survivors so that when Dr. Dye and Dr. Hoover and the distinguished guests at the panel that are great physicians, when they find out that we need the survivors because they do have gold in their blood, such as Dr. Dye said, these are the folks that will remember us, and they'll be able to come back and say, we want to make a difference, because at the end of the day, it's only as good as their survivors to give blood, and that's important in plasma, I should say. My last slide is really just this initiative that we had. We had a lot of the chiefdoms, both in Liberia as well as Sierra Leone. And what we're trying to do is evergreen the opportunity. When we see something, we take advantage of the situation to help out. And that's thanks to Vicki Tift, as well as some of the other folks with like Waves for Water. Jack Rose, Vicki and I had met Jack Rose at the Bill and Melinda Gates Partnership Foundation a few months ago, and we were able to get several buckets to get a filtration system to give not only the survivors but the community at large clean water, because that besides Ebola they also have to deal with very unsanitary conditions and unclean water. This filtration system, you can definitely Google it and you can see, and Jack Rose will call you immediately if you're interested. This is a dynamic way where you can get clean water instantly, and it gets a lot of the pathogens as well as the protozoans and nasties that you don't want to talk about, but that makes you sick. So I would really like to just say that if you want to give somebody 150 gallons of water a day, this bucket can do that, and it's $50. So I recommend that you guys take a look at that if you're doing studies globally. This is something that could dovetail into it and also add value and make a difference. So with that, I'd like to turn it back to Dr. Salata.
I think we're going to set up for the panel and the questions. The only other advantage, Joe, is they drive on the right side of the road, right, in Liberia. Very Americanized in many ways, unlike what Henry and some other colleagues and I face when going to East Africa, where it's the British way. So we can have the panelists come forth while we're setting up, but I'd like to start the questions with and make a comment first, and that is there appears to be a great deal of interest in what is now being called a post-Ebola syndrome in these survivors, with many manifestations, including bone and joint complaints, eye disease, including blindness, as well as central nervous system problems. There's been the reports of many months out from cure of sexually transmitted infection from men to women in the context of finding the virus still in semen. So these are issues that in the aftermath of recovery for many of these survivors that we're still trying to sort out. So I wanted to ask Dr. Brown first to comment on what he's seeing in that respect, first of all, and then to describe what they're doing in terms of setting up survivor clinics in Liberia. Please.
Oh.
You can speak right into it. Yeah. Oh, please.
Well, thank you. We currently in Liberia we have 4 survival clinics. The idea about survival clinic actually started when I got called by most of the survivors I was putting out, begin to call and say, oh, I have joint pains, I have memory loss, I continue to have a headache. And so I then said to myself, there's no way I could continue working in the ETU and at the same time address their conditions. So I then spoke with one of my family medicine physicians and said, I think it was going to be wise that we establish a clinic for the survivor to attend to them and know what their needs are. And so having done that, we had a group that visited us, and I think they have done a publication already on the ocular complication for their post-Ebola syndrome. And so the NIH, together with another research group in Liberia called Prevail, has established 3 other survival clinics. So we now have 4 in addition to the one that we have. Thank you.
So this seems to be a longer lasting problem, even in the aftermath of recovery. John, maybe you can speak a little bit more about some of the studies longitudinally that you and your group are involved with.
Sure. Is this on? I guess so. Anyway, great. So as I mentioned in the introduction, we've been traveling to Uganda looking at survivors, and we've been evaluating over 200 survivors from multiple outbreaks. The first was in 2000 in the Gulu region of Sudan, and more recently in 2007 in the Bundibugyo region of Uganda, Bundibugyo virus. And then in 2012, there was a concurrent outbreak of Marburg in Sudan in western Uganda, and we've been following all these patients over time. And one thing that's really interesting is that I went back, we just were in Uganda in August, and I was looking, and we collected from 75 individuals, and we do a questionnaire as well as allowing us to take their product. And I would say 75% of them complained of backaches, arthritis, headaches, sleep apnea, as well as vision issues. And in the past, we've always looked at this, and it's very difficult because in Africa, you're constantly barraged by all kinds of pathogens. If you also look at the same survey, within the last year, 95% of them had been infected with malaria. So how do you differentiate a sequela event from an event that actually is more proximal than that? So what's different about this outbreak is that Westerners have been infected, and they've come back to industrialized nations where they're receiving top health care, and yet you're now seeing sequelae. And I think that's very important, and we're going to learn a lot from the Scottish nurse, from Ian Crozier, and other people like that.
So Dave, maybe you could start a discussion in and around the vaccine initiatives in these areas. And is this really a viable strategy? And how can that be ramped up if it is?
Well, I think the vaccine initiatives are very important. I think the ring vaccination strategy that was used in Guinea looks very.
And for the audience, can you describe what that is, please? The ring vaccination.
Right. So a ring vaccination strategy is that when you identify a contact, you vaccinate. You identify an index case. You vaccinate all the people who have contact with the index case, and then it can sequentially spread out to vaccinate the contacts of the contacts. And that's a strategy that was used to eradicate smallpox. And that was actually the trial design that was used in the Guinea trial for Ebola vaccine, and that those results look very promising. So I think that vaccination even vaccination of contacts is actually a very useful strategy. It may not be feasible to vaccinate an entire population against a disease that most of the time is very sporadic, but I think that shows promise. If we could couple that with a therapeutic that could be used for the contacts as well, to take care of the people who get infected in the week before the vaccine can be effective, and then we can have therapeutics that would treat the people who escape, who get infected despite those efforts. I think we will have won the game.
One last question for me, and we'll open it up to the audience. Obviously, as many of our speakers have indicated, there are coexistent infections going on all the time in this area of the world. So, but that also provides an interesting opportunity to look at the interaction of some of the other viral infections, such as HIV or hepatitis, some of which have been mentioned already. John, what do you think about that? And for instance, because HIV is prevalent there too, how do you think that affected the Ebola patients in West Africa?
So with a person who has HIV or AIDS, with their CD4 population being decimated, I think it's going to have a great effect. But more importantly than that, it's actually kind of a catch-22, and we don't have enough data to know, and maybe we'll have enough data after this. But one could also make the alternative argument that if someone has a heightened immune system because they're constantly being barraged by other bacteria and viruses, that maybe their innate immune response is actually heightened so that they actually could survive better when they come into contact with Ebola. So we don't really know enough to know. And I think if you look at the number of cases of Ebola that have occurred since 1976, there are 5,000 cases before this outbreak, total. And now you're talking about 9,000 over that have succumbed, and tens of thousands of survivors. So our N just got huge. That allows us to look at this, and we just need to now dissect the data.
Right. I agree. Questions, we welcome any of you from the audience. And we're going to have microphones, so identify yourself for us, please, and give us your question when you
Chuck
just...
Aaron, I'm Western Reserve class of 62.
Great.
Had good fortune to be in public health service in the smallpox eradication program. And I think you mentioned something about smallpox. When you talk about developing vaccine testing programs, the one thing that smallpox had a great advantage for was you could set up surveillance and find a probable cause, and pretty close to it. All you had to worry about really was chickenpox. Right. Is this varicella or variola? And so I'm wondering, is there anything in the clinical picture of Ebola that you could set up early detection for, to try to find it before you wind up with 3,500 cases or something of that sort? Is there a way that you could set up your surveillance system to, in some key areas, to look for, like we were talking about, fatal rash? Then we would jump out and go and look around and see, did you have anybody with recent scars? The immediate post or early smallpox, right after when the scabs fall off, you have depigmented patches. So we could go to market day and look around and look for recent people walking by with white scars on their face. And that gave you the idea that you had recent disease. So is there anything in the Ebola picture that might give you clues to find early cases?
So thank you for your question. Let me start by saying, as Dr. Brown showed, the clinical manifestations are fairly protean, very diffuse. And there are so many other etiologies, infections, especially in these parts of the world, that can present in the same manner. So setting forth a case definition of Ebola, especially for early stage, is very difficult. Therefore, it's going to rely upon early diagnostic approaches, and I think point of care diagnostics are really the key here to undertake the kinds of things that you're talking about. But Jerry, do you want to comment on that in your own case? Could you, unless they're hemorrhaging and a number of other things, that's pretty far along, so that's not your point of comment. So how could you early on, Jerry, from a clinical standpoint, distinguish malaria from HIV infection, tuberculosis, and a number of other things that may be very difficult?
Well, from our experience, it was not possible to, from your physical assessment, distinguish Ebola from malaria. Right. That clinic, laboratory investigation was the primary means of concluding, because even initially people rely on bleeding symptoms, but we realized later on that close to 50% or more of our patients never had any bleeding symptom. They presented just like someone with malaria or any other thing. So I think laboratory investigation or diagnosis is the primary route for now. Except John has something.
So this gets back to John's initiatives in helping to develop rapid diagnostics for this, and I think that's going to be the key. John, do you agree?
Mm-hmm. I totally agree. Having a quick turnaround PCR result, probably PCR isn't even the best way, a lateral flow assay, a dipstick test that can give you a positive or negative result within 30 minutes would be key. But I think to your point of how do we stop this from where we have 35,000 people infected again, Ebola has been popping up all over Central Africa for decades. And the difference with this outbreak is that, for instance, if you compare it to Uganda, we're talking about dozens of cases as opposed to tens of thousands. The difference is that Uganda had seen it before. And it had never been seen in West Africa except for one case in Cote d'Ivoire, and it was believed to have actually migrated to Cote d'Ivoire from Central Africa. So ecosystems have maybe changed with reservoirs to move the virus into Western Africa. They weren't prepared, and with the general symptoms that Bob was talking about, general malaise. You can't really put your finger on it. It was probably early diagnosed as Lassa virus, would be my guess, because the symptoms are so similar. So now I'm sure they'll be more aware. And in Uganda, there's a very rapid response where they basically isolate individuals who are suspected, and they stem the infection in that way with good laboratory practices like Dr. Brown initiated at Ebola.
It was also pointed out by Jerry about some of the means of transmission that were also seen in other African countries, but remember a couple other distinguishing points. This was more urban-based in many ways than the other outbreaks that were in remote rural areas. Yeah. And the death rates were so high in those areas, it came and went as fast as that. This was not the case here, but to their credit, we saw mortality rates decline here, mainly through standard of care and infection control practices. And I think that is a starting point. Now we need to move, as Dave said, to therapeutics, prevention with vaccine, and a number of other things. But in my opinion, as John pointed out, the key will be to study the survivors, right? Questions from the audience, please. We have one right here.
Dr. Dye, you mentioned...
Please identify yourself too, please.
I'm Paul Pereski. I'm on the board of ClinicalRM.
Hi, Paul.
Dr. Dye, you mentioned that the survivors have gold in their veins, and let's say that this lies dormant for a couple years, 3 years, 5 years. Is there a database or a way to track? I mean, I'm thinking tracking people in Africa is probably more difficult than in the U.S., but I mean, we may need to call upon them for the plasma that's in them down the road.
That's exactly correct. So I think the databases that are being developed by CRM and the infrastructure and the networks of the survivors that they're setting up allow you to do this. And I'll give you an example just from Uganda again. There was an outbreak in 2012. We were in Gulu in 2012 collecting from survivors. They had heard about the outbreak 7 hours away, and they were asking if they could go help treat the patients of the current outbreak. So I'm amazed at the resiliency of the African people, their willingness to give, and the willingness to help. When there's a problem, they come out of the woodwork, and I think with the databases and the network survivors, along with their own inherent goodness, they're going to come out to help in the future.
Okay, thank you.
Other questions? You have one in the back, please.
Hi, my name is Farah Rahman. I'm a third-year undergrad at Case Western studying global health. And I have a question about the healthcare infrastructure that was established in West Africa and Liberia and other countries after the Ebola epidemic. Like Dr. Brown was saying, there were a lot of heightened PCR capabilities and whatnot. So I was wondering how this infrastructure would be maintained after the epidemic, and whether there would be some economic policies, maybe from the World Bank or other sources, that would help facilitate this maintenance.
Great question. Craig, do you want to start?
I think there's probably two ways to address this question. One would be from a purely scientific medical perspective, and then also probably from just a regular foreign investor perspective. And I know that, for example, the government of Sierra Leone has reached out to us, and even though they've made improvements and they have contained Ebola much more effectively than at the beginning, foreign investors who don't have the background that 99% of you in this room have aren't buying it. And basically markets work because there's confidence. And as of right now, there's a gap in confidence. And I had the privileged conversation with Dr. Jerry Brown that perhaps the medical community feels in the 3 hot zone countries that Ebola is under control, but that hasn't been communicated to other branches of government in these countries. I think that if we were to just take a step back, though, we still have a long way to go, because we know that just across the board, health infrastructure is still substandard in West Africa. And crises present opportunities. And what we're hoping is that we can establish a multidisciplinary approach where you have doctors, scientists, lawyers, economists, diplomats coming together, international, local, And bit by bit, we can improve the infrastructure. And that's hopefully where World Bank participation together with the private sector can help.
Thank you. Any other comments from panelists? Joe?
I'd just like to add one other comment to Craig's point. There is some significance that we're working with, especially since he just mentioned Sierra Leone. You know, I had the privilege of working with Dr. Baker at the National Blood Bank to get this convalescent plasma off the ground. And there was a lot of collaboration. They realized their constraints of a 20 by 20 room for the National Blood Bank that needed some severe repairs. So what we did is we knew that we were over our head in some ways with finances, and we went to the foundation folks and we found out that they were very interested in collaborating and building the blood bank, and not only building it, but maintaining it and training. So what you have now, if you look 2 years, 3 years into the future, Dr. Baker will have a lab that's been self-sustaining now. They're able to collect plasma thanks to the folks on the panel and you know, some of the generous donors that we mentioned. And that's for the future. Before, the country of Sierra Leone didn't have the ability to plasmapheresis. So if we even go outside the Ebola crisis, think of what plasma could do for any of the other diseases or just the needs of banking plasma. They have now freezers thanks to this crisis and thanks to ClinicalRM going in there with supplies. And we have one gentleman in the audience, Mark Sprentz, who actually volunteered to give his plasma to try the machines out. So the efforts that are being done from many of the different countries and different NGOs is amazing, because we understand the need that we have to leave a footprint in these countries. It's absolutely essential. Past Ebola, this elusive disease that everyone on the panel is talking about, you have to make a difference, and you have to give confidence to the country that you're not going to leave.
So that's the most important legacy, to leave something behind and to improve the situation. We have much work to be done because there's been such devastation. The coalition that Craig has pointed out, that Case Western is very involved with as well in trying to create, is not just for this current situation. What happens when Ebola comes back again, and it will? Will it be in West Africa again or elsewhere? What if we have a different viral outbreak, and that's happening worldwide? How do we handle that? So I think that's an important part. But the legacy and not going in a short-term way, leaving something behind, making them better, is really the key to this. Jerry, do you want to comment on that?
Yeah, thank you. If I may support the view of Joseph and John, we have partners coming in during the outbreak, and they did work with our government and other local entities. As Joseph said, it would be a good idea that a lot of them begin to pull out already as a result of the end of the crisis. But leaving something behind is very essential. You saw the need initially. There were acute shortage of trained manpower to handle the crisis we had initially. In addition to that, a lot of our trained manpower, trained physicians who started the fight, died. You know, the infectious disease doctor in Sierra Leone, he died. We lost 2 internists, the only 2 Liberian internists we had in Liberia, died as a result of the disease. And just pulling out without helping the 3 countries to tackle the problem they had initially before the crisis, I think would not be of any benefit to these 3 countries. If you look back, there was nothing like a research entity in Sierra Leone, Liberia, or Guinea. If we can begin to think about having a regional research group set up perhaps in one of these countries, if we can begin to look at having a regional response team in one of these countries, or having a regional response team in various parts of Africa, such that once you have an outbreak, the team will begin to strategize and move on to curtail the spread of the outbreak while waiting for international support from elsewhere. I think that was lacking during this outbreak. So I think partners should continue to collaborate with the affected countries and not just leave them alone to work by themselves.
Other questions from the audience? Right here, please. Somebody will bring you a, oh, you have one.
Thank you. I'm Hugh Pace, very proud to be associated with ClinicalRM on their advisory board. I'm not a scientist, I'm not a doctor, so please excuse the vocabulary. However, there was a concurrent outbreak in 3 countries, or epidemic in 3 countries, Guinea, Sierra Leone, and Liberia. Did the disease manifest itself in the same way in the 3 countries? Were the facilities to treat infected people similar or very different in the 3 countries? I should say the manifestation of the disease itself, was it very similar in the 3 countries? In the Time magazine article, which of course had very limited data, and you have to wonder if it's questionable and if the reporting means are the same between the 3 countries, but it seemed to indicate that there were different mortality rates in the 3 countries. Was this really the case? And if so, why? So I guess I'm curious about what were any differences that you may have noticed between the 3 countries? Thank you.
So I think Jerry has discussed this with colleagues from the other countries. Do you want to start answering some of that? And I know Dave and John and others have been to several of these countries, Joe as well. Maybe they can add some additional comments.
I stand to be corrected. Thank you. I stand to be corrected. Not been, I was not in Guinea, but I visited Sierra Leone and I had a chance to have some idea about how the patients were attended to in terms of management. It was quite similar to what we had in Liberia. I don't think the clinical approach attributed a lot to it attributed to mortality though, but one of the factors responsible for a lot of patients dying in most of these countries were cultural practices. Was one thing that we should take into consideration. The belief and concept people had about the disease initially, hence thought it wise not to report to health facilities for early treatment. Like in Liberia, people thought we clinicians were dressing in whatever outfit in order to extract organs from those that were reporting at the ETU, so they thought it wise not to show up, and that was widespread in the country. So instead of showing up for treatment, they chose to remain home. And that led to a rapid spread and increase in mortality. So the concept people had about the disease also led to a lot of deaths. So it was not only attributed to the treatment protocol we had in various countries. I think I think in Sierra Leone, they were also giving adequate fluid for managing patients there as well. So patients started recovering. But initially, we all never had much knowledge about how to take care of this patient until we started having international partners and sharing ideas with people. I don't know whether you have anything
Dave,
to add.
do you have any other comments?
I just say that actually the majority of the patients that were taken care of during this outbreak were taken care of by Doctors Without Borders and in their own treatment units. And they were so overwhelmed with patients compared to physicians and staff that they did whatever they could to replenish fluids and electrolytes. But I think that it's hard to say whether differences in mortality rates in West Africa, how much that was affected by changes in care. I think the outbreak really was controlled largely by case finding, isolation, and education to improve practices.
Joe, do you have a comment?
I would just say, just to Hugh's comment or question, Dave hit it spot on. I think as I was able to tour a lot of the different ETUs in several of the countries, it's really supplies limited, and it's also how quickly you can get the staff from the Doctors Without Borders, and I think that had a big play on the morbidity and mortality and the response. I mean, some of these folks that would come into the hospital, we were able to see that it was just too late. So I think they were either up country or in a very difficult area to get to, so by the time they got to the hospital, especially in Military Hospital 34 in Sierra Leone, you know, unfortunately, there was nothing that they could do for them at that point. So I think that plays a factor in the data you're talking about.
So one additional issue that Jerry had mentioned is families would hide individuals who were symptomatic because there was such stigma and fear about this that they often did present late. Craig, you had a comment as well.
Well, during this period, we were also working with UNICEF, and UNICEF's Ebola head unit was located in Dakar. And their two observations were that two things were posing challenges for certain spikes was that a lot of the Ebola outbreak in Guinea-Conakry was occurring in the forest area. So that presented the challenge. And then, surprisingly, in Freeport, there was just a mismatch between supply of ETUs at the beginning and the number of patients that they had. And so these two forces were partially responsible for the spike when things were getting very bad.
So one other thing I'd just like to state is that there has been enormous criticism at the response of international organizations and institutions in coming to help out. Jerry, do you have a perspective on this? And this includes the U.S., by the way, and I think we should acknowledge that. How can we do this better in the future? And how important, you had to fend for yourselves, so to speak, at the beginning. How can we start to address this in a better way?
Thank you. If I may add to my first comment, to some extent, the inadequate supply and the maybe wrong type of supply also contributed to the mortality rate we had in our setting. For example, because we rely primarily on donation, we never got the type of, for example, IV fluid we felt was important for ensuring adequate resuscitation. We got like 500 milliliter of ringerlatate, and man, it's difficult going in and out to put up a 500 milliliter bag of ringerlatate to resuscitate someone if you intended giving them 3 liters in, say, 2 or 3 hours, because you can remain at the bedside. Unlike our request we made was we wanted either 1 liter bag or 2 liter or 3 liters bag, but that was not forthcoming. And we found ourselves in a situation where we ran out of basic medications like anti-malaria. We just couldn't find it, so we had to go like on the radio and begin to ask philanthropists in Liberia, or perhaps ask the ordinary Liberians to come forth with supply. There were times we couldn't get mineral water for the patients. So after we made this appeal on the radio, then Liberians began to come in large number and purchasing beddings and other things for the patient, purchasing. That's how we got in contact with other groups in America, and they too begin to supply, send supply. So the delay in response from the international community also had an adverse effect on what was unfolding. And I also blame ourselves from not looking around and see how we could best make use of available resources to start the fight while we waited for the coming in of other friendly organizations. Another thing I noticed was most of these friendly government or NGO that came in to kind of say, please their parent body. Say the WHO came in as to whatever intervention that was executed, for example, was to say the credit goes to WHO. If the US government came in, whatever was done by the US government team, the credit went to the US government. If the German team came in, so it was like the German went by themselves, the Chinese went by themselves, the Americans went by themselves, and there was nothing like coordinating their effort and saying, we've done this collectively, but the Chinese will want to do it and say yes and report back to the Chinese government and say, yes, it was the Chinese that did this. And so that's the situation we had on hand. So you go to some ETU and realize they have all of the diagnostic capability. They could do X-ray, they could do anything you thought about. I went to another ETU, there was nothing. So it was like MSF was next door to us. They had stockpile of IV fluids and anything they wanted. But when it came to our ETU, we had to look for food cover. We couldn't find food cover, so we went at the supermarket and bought plastic bags and cover our feet in order to work, because the absence of food cover did not mean you can't attend to your patient. We decided to look outside the box. So I think the next time we have an outbreak, these friendly organizations that come into work should forget about, say, their own gratification and see how they can work together collectively to attend to the outbreak and attend to the problem, attend to what we have on hand, and not just, oh, okay, we will keep our team by ourselves and let our team work by ourselves and report to us. That's the situation we had.
Yep. Well said. There were some other questions here, please. So if you could wait for the microphone.
Hi, my name is John Piles. I work here at EpiBio and specialize in sequencing. Just out of curiosity, this is probably a more question for Dr. Dye, but I know that we've seen Ebola RNA months after patients have recovered. Has anybody recovered viable virus? And if so, where? I mean, because you mentioned the eye, the nervous system, semen, you different areas. So has this been accomplished yet?
So the only documented case of, like you said, PCR will determine the genetic material, which does not tell you infectious particles. The only documented case of infectious virus being isolated from a survivor months after is actually, the documented cases is Ian Crozier, which was the eye in Emory, where they actually were able to culture the virus that came from his eye. So there was these immunoprivileged sites, like the eye, the testes, the central nervous system, can harbor these viruses and other viruses like HPV and other viruses for months to years. We didn't really know that occurred with Ebola. There were reports from earlier infections of significant others or sexual partners of outbreak survivors months after infection becoming infected, but this is all anecdotal. This is the first really documented case, and now the nurse in Scotland. So there's a lot of research that's going to need to go on to understand, is there infectious virus, and what are the levels of that virus, and can it be spread from person to person, and how do we go about assessing that? It's a very difficult question to answer and an excellent one.
But a very important one. We were supposed to have ended at 5:30. I don't see anybody leaving the room. So we have time for a few more questions. I think there were some here. Yes? Yes. Thank you.
Hi. Thank you all for your very, very informative talks. My name is Untitled Chapter. I'm a first-year medical student here at Case. My question has to do a little bit with, I guess, the government policies that are being implemented in Sierra Leone, Guinea, and in West Africa. We've heard a lot about NGOs, and we've heard a lot about private organizations and research companies. But in terms of what would you guys like to see that the specific government organizations do in response? Have they done enough after this crisis is done to leave themselves prepared for the next crisis, or are they becoming more and more dependent on external entities to help them respond? Has there been a level of independence that's been reached?
That's a good question. Jerry, do you want to start? What is the Ministry of Health and the President in Liberia doing?
Currently, what the Ministry of Health has done thus far is to first do a health assessment and try to look at the weaknesses in the health sector prior to Ebola, and try to look at where we are now post-Ebola, and now working toward how we can improve on those weaknesses, especially when you have to do with poor referral and poor dissemination of health information, poor health infrastructure, and poor human resource development, and improving and diagnostic capability in the country. And currently there are partners that are making donations, like the World Bank, the African Development Bank, to the government, and often, as we speak, the government is still making plans on what to do with some of the available resources. But I think we should, as I said earlier, we should not, it would be wrong if we just left all with the government alone in her planning process. If friendly organizations that existed during the outbreak don't leave back some of their manpower to work alongside with the government and see how we can set up a better infrastructure. Because, for example, Liberia never had any level 2 or 3 laboratory before it never existed in Liberia. If you want us to have one, then people like Dr. Dye need to be around and see how we can guide the government in having one established, and not just say, okay, you need to do one and then you turn your back. Okay, and I think we still need more collaboration to move ahead. I don't know much about Sierra Leone and Guinea.
Greg, do you have any other comments relating policy making and
I think Dr. Jerry Brown focused on the key issue. When you're dealing in international development affairs, it's always a big who takes the credit issue. And I like to refer to Dr. Salada's point that one of the main points of establishing this International Infectious Disease Coalition was to try to create this collective teamwork mentality. And there is a lot of duplication, lack of coordination. And I think, however, one of the positive signs was the ECOWAS community that I referred to. This was the first time when the 15 countries banded together and ministries of health were talking to one another, and the Francophone countries were speaking to the Anglophone countries. And I think this is an issue where the international community, World Bank, African Development Bank, together with key private sector players, working with the local governments. I think this is the way, again, to figure out what's the comparative advantage of each and to leverage that and then to go forward. I think that's the correct policy approach. Now, the implementation is going to be difficult, but you have to start somewhere.
So I want to take the opportunity to thank you for coming, to thank our panelists for enriching this discussion. This has been incredibly provocative, and I think we need to think about the context of this. And we saw the effects of global travel and how close we are in terms of this even coming to the Cleveland area. That said, this was a devastating epidemic. This will occur again, I predict. It may be elsewhere. And we'll see epidemics of other infections And so therefore, we have to be more global in our thinking about disease and how that can reach our borders as well. The amazing effort that was put in play by our colleagues, such as Jerry Brown in Liberia and the other affected areas, is incredibly applaudable and admirable. We do need to move forward studying the survivors, as was mentioned, because that will give us, I think, clues to how to prevent this, or at least detect this at an early stage, and understand the elements of a post-Ebola syndrome, which we're beginning to just realize. That said, as Dave Hoover pointed out, we need therapeutics here. We need vaccines. And I'd also like to congratulate our ClinicalRM colleagues for their involvement at an early point where these other agencies were not stepping up. And I think that's a manifestation of their mindset, and they're not backing away from this. And so I'd like to congratulate them again for this, and for partnering with Case Western Reserve University. We have a great footprint here in terms of our international health activities. Some of you may know that Case was just named for the second time in a row as the #1 institution in the country for our international health efforts. And this goes beyond infections. In Uganda, where I work, and some of my other colleagues, we've expanded our efforts in cardiology, neurology, cancer, genetics. There is so much to do. These things that happen there are the same things that we face, but we have to have this mindset. So with that in mind, I really want to, again, especially thank Jerry for coming. He is an amazing man. He doesn't like to be called a hero, but I consider him one. So thank you very much.